Hello, and thank you for joining this OncLive peer exchange entitled The Divide and Conquer of Advanced Colorectal Cancer. The flood of information regarding the clinical subtypes of colorectal cancer is bringing the field closer to a precision medicine model. This OncLive peer exchange panel of experts will discuss tumor biology, guideline updates, liver-directed therapy, and sequencing while providing the latest evidence within a context that allows for practical application in the clinical setting. I'm Dr. John Marshall, and I'm Chief of the Division of Hematology Oncology at Georgetown University and the Director of the Rush Center for the Cure of GI Cancers at Lombardi Comprehensive Cancer Center in Washington, D.C. Participating today on our distinguished panel are Dr. Johann Bendell, Director of the GI Cancer Research Program and Associate Director of the Drug Development Program at the Sarah Cannon Research Institute in Nashville, Tennessee. Dr. Tanios Bekaii-Saab, the co-leader of the GI Cancer Program and Research Associate Consultant for the Division of Hematology and Oncology at the Mayo Clinic in sunny Phoenix, Arizona. And Dr. Alan Venook, who's the Shorenstein Associate Director for Program Development at the Helen Diller Family Comprehensive Cancer Center and Professor in the Department of Hematology Oncology at UCSF. Alan, great to see you.
Thanks, John.
All right, guys, we got some work to do. There's a lot going on. We're going to start with this whole thing about right versus left colon cancers. Alan, you caused the problem when you went through every chart of every one of your patients on 80405, of all the patients on 80405, and finally sort of confirmed for us data that we had sort of known for a while. Take us through what you how you did it and what you found.
Well, doing it was the time-consuming part. The issue, getting the idea was not a new idea. There have been a few small publications of small series of patients suggesting that there was a difference in outcome. Then I happened upon a report from about 15 years ago in JCO from Scott Wadler was one of the investigators, and that study, which was all 5-FU-based chemotherapy, had shown a 5-month difference in survival, left versus right primaries. And it occurred to me, well, obviously that's something we should have looked at. There are a few new series suggesting that. So we hadn't captured that information prospectively, though. So I went back into all the medical records of the patients. It was about 2,300 patients in total.
Just 2,300 patients.
In 80405. It took me a while.
Took you a weekend, right?
I had a couple of long trips. And I basically determined sidedness and really looked for definitive evidence of sidedness. Sent off a spreadsheet to the statisticians and forgot about it, and then 6 weeks later, I got the analysis back, and it just blew my mind.
So for our audience out there, so how did you end up dividing? What does sidedness mean?
So to me, we looked at, we had transverse colon, we had right-sided colon cancer was the cecum to the hepatic flexure. Hepatic flexure to splenic flexure was transverse colon, then splenic flexure down to the anus, in fact, was left-sided.
So including rectals in this?
We found it was very difficult to determine what was rectal and what wasn't. And so I just lumped rectal cancer with left-sided cancer. And then as we did I'd say many patients, about 100 patients, we couldn't categorize. No matter how I looked and searched, I couldn't figure out where the primary was. And so we stuck with that. And then as we did the analysis, the transverse colon really felt intermediate between the right and left side.
So there weren't that many of them either, right?
Correct. The transverse colon was constituted maybe 60 cases, so we just elected not to report on them, and just for simplicity's sake, took right versus left and looked at did that comparison. And the comparison was eye-popping. I mean, literally more than a year's difference in survival, left versus right. Which we just found, which was stunning.
And all of these people were still getting all the drugs, right? So they were being treated the same way.
Absolutely.
Just survival
it was a randomized study. The two arms did exactly the same. So in fact, every patient was suitable for analysis for the sidedness question. And then as we dug into it, we discovered some really stunning things, which have now been confirmed in a number of subsequent analyses. We found, for example, that right-sided patients, these were all RAS wild-type patients. Right-sided patients had no benefit from EGFR antibodies. The difference in survival in a right-sided patient who got EGFR antibody was 20 months between right-sided and left-sided. So left-sided patients who got EGFR antibodies had a 20-month better survival than right-side. Just
But
stunning.
do we know that they didn't have benefit? They just didn't have as much, right?
So it's hard to say, right? There's only one study that informs whether there's benefit or not, or harm even, and that's Crystal. The Crystal study, which was subsequently analyzed, showed that there was probably not harmful, and maybe a little bit of benefit on the right side, but much more benefit on the left side. In our study, I can't say how much the benefit was. And the other defect or other issue in our study is some patients got FOLFOX and some got FOLFIRI. 3/4 had FOLFOX, a quarter had FOLFIRI. That may be another variable that will play out. But
so Tony, help me with this. So, you know, Alan gets up there and says that right-sided colon cancers do not seem to be really have much benefit from EGFR therapies, even in the right molecular profile. Why is this happening? Do you have any sense about the biology here, or why this might be so?
So I think we still have a way to learn about the biology, but there's certainly a biologic factor, a molecular factor, and Alan will be presenting more data along the year, which hopefully will clarify a little bit to us why that group of patients in particular may not benefit as much from EGFR inhibitors. It is interesting. Of course, it's a first-line phenomenon. It changed the NCCN guidelines. There's a statement in the NCCN guidelines that essentially refers to RAS wild-type, right-sided, to avoid or not use EGFR inhibitors. I think the problem with this is how does that apply to later lines, not as much front line. You know, in front line, the majority of U.S. practices, including mine, you know, still overwhelmingly use bevacizumab. So that doesn't really change what we do. For some practices, it may affect what they do. But for later lines, the data is less clear. I mean, do you have a patient who's RAS wild type on the right side, and you use chemotherapy plus bevacizumab in the first line?
Let's come back to later lines in a minute, because I really want to talk about sort of this front line question. So, you know, when I'm seeing a new patient with metastatic disease, you know, I know there are a bunch of different ICD-10 codes for, you know, where the cancer is. And sometimes I'm trying to pore through to figure that out. So it matters?
You know, I think it does for now. I think that right now, sidedness is probably a surrogate for some type of biomarker profile that we don't completely understand yet. And as Tony alluded to, Alan's going to be presenting some more data to try to hone in a little bit more on the biomarker profiles that might be associated with these outcomes that we're seeing. But I think we don't know the whole story yet.
Yeah, and so I need to know where it came from. What if I'm treating somebody and do I need to go back and figure out where that primary was?
Well, so the answer is maybe yes, maybe no. I think, as Tony said, this is really our study only looked at first-line use of therapy. Now, there are other studies that have looked at EGFR antibodies in the same population, right versus left side, and also don't appear to show much benefit. But I think the answer is it's important. The main question, though, is, again, are we harming patients with EGFR antibodies? Probably not, although there's the opportunity loss and there's a toxicity that you'd rather not face. One fascinating subset that we had, and we will hopefully explain soon, is in our study, the pre-amendment study, the cohort, where we started out treating all comers, and in fact, so a number of patients with RAS mutations were included in the study. In those patients with right-sided primaries who had RAS mutations and got cetuximab, they had an 8-month better survival than patients with right-sided primaries that were RAS wild-type who got cetuximab. Now that's an upside-down finding, but it makes you really think there's something else going on. Clearly, RAS is not the dominant driver on the right-sided cancers, and there are other factors that are involved.
How does this data change your thinking about molecular testing in a brand new metastatic colon cancer? Do you need to know right away still, or if you have a right-sided, you don't care?
I think in the first-line setting, when I see that patient for the first time with metastatic disease, the things I want to know right away is actually more microsatellite status, and we can talk a bit more about that in terms of decision-making in the first line. Right now, I don't know that there's enough data that I believe is solid to say that it makes a difference when my go-to regimen is a FOLFOX bevacizumab regimen. I think it would make more difference if I'm considering an anti-EGFR therapy. So I'll go ahead and get people started, but I will send off molecular profiling on those patients right away.